Marcus is 34 years old. He's an architect. He is, by every measurable standard, a healthy man. And he is standing at the edge of a bathtub at 2 a.m, running cold water, thinking about ice. Not in the way a person thinks about a drink on a hot day. He's thinking about ice the way an engineer thinks about a solution, methodically, with relief. He has spent the last 6 hours at his drafting table, unable to work. His left leg is there. He can see it. He can feel it. And yet something about its presence is intolerable to him in a way he cannot fully articulate and has never been able to articulate. It is not pain. There is no injury. His leg is, by every clinical measure, perfectly functional. And that, he will later tell a psychiatrist, is almost the worst part. The wrongness is not in what the leg does. It is in what it is. He fills the bathtub with ice. He has read, on a forum he has visited in private browser windows for 3 years, that extended exposure to extreme cold can cause enough tissue damage to require surgical removal. He knows this is dangerous. He also feels, in a way he cannot defend but cannot abandon, that if he could simply remove this limb from his body, he would finally be whole. He sits on the edge of the tub for a long time. Eventually, he gets up. He goes to bed. He does not sleep. This is not the first night like this. It will not be the last. Body Integrity Identity Disorder, or BIID, is a condition in which an otherwise cognitively intact individual develops a persistent, profound sense that one or more of their limbs, or occasionally another body part, does not belong to them. The affected limb is healthy. There is no neurological damage, no chronic pain, no physical pathology of any kind. And yet the psychological experience of that limb is one of deep, irreconcilable wrongness. The condition was first formally described in the medical literature in 1977 by psychiatrist John Money, who used the term apotemnophilia, a term that has since fallen out of favor because it implies a primarily sexual motivation, which researchers now understand applies only to a subset of cases. The more clinically precise terms used today are body integrity identity disorder and body integrity dysphoria, the latter appearing in the ICD-11, the World Health Organization's International Classification of Diseases, where it was formally recognized for the first time in 2022. BIID is considered extremely rare. Prevalence estimates are difficult to establish because many sufferers never disclose their condition to a clinician, but surveys of online communities suggest the disorder may affect several thousand individuals worldwide. The vast majority report that their feelings began in childhood, often before the age of 10, and that no single traumatic event preceded the onset. The limbs most commonly affected are the legs, particularly below the knee. Most sufferers report a precise and consistent boundary, a line on their body below which the limb feels foreign and above which the body feels correct. That specificity is one of the features that most troubles and intrigues researchers. It is not a generalized bodily dissatisfaction. It is surgical in its precision. BID is not psychosis. Sufferers are not delusional. They know the limb is physically there. They know it functions. What they experience is closer to an identity mismatch, a conviction that their physical body does not match an internal image of what their body should be. In that sense, clinicians have noted structural similarities to gender dysphoria, though the two conditions are neurologically and psychologically distinct. Marcus had never heard the term body integrity identity disorder until he was 31 years old. By then, he had been living with the condition for more than 2 decades. Marcus grew up in a mid-sized city in the American Midwest, the second of 3 children in a household that was, by his own description, unremarkable in the best possible way. His parents were stable. His childhood was not marked by abuse or neglect. He was a quiet, observant boy who liked to draw buildings and read about how things were constructed. He was good at school without being exceptional. He had friends. He played recreational basketball through middle school. He was, in short, a person about whom there was nothing that would have predicted what was coming. He studied architecture at a state university, graduated on time, joined a small firm, and by his late 20s had established himself as someone his colleagues described as meticulous and calm. He married at 28 a woman named Diane, a physical therapist, someone who understood bodies in a professional way that he would later find both comforting and painful. They had no children. They had a dog. They had, from the outside, a life. Marcus ran. That detail matters. 3 mornings a week, 5 miles, the same route through a park near their apartment. He ran because he liked the rhythm of it and because it quieted something in his head that otherwise never fully went quiet. He was not an athlete performing. He was a person trying to feel normal in a body that had never entirely felt like his own. He had learned over many years to manage, to compartmentalize, to redirect. He had never told anyone, not Diane, not a doctor, not a friend, about the thing he carried. He did not yet have a name for it. He had only the sensation that his left leg from approximately 4 inches below the knee was wrong. Not painful, not diseased, simply not his. Marcus's earliest memory of the feeling is from when he was 7 years old. He does not remember a specific incident. He remembers instead a quality of attention, looking down at his leg during a school assembly and having a thought that he could not yet formulate but that registered as something like, "That part doesn't go there." He did not tell his parents. He was 7. He had no framework. Children accept the strange contents of their inner lives with a pragmatism that adults often lose. In the years that followed, the feeling did not go away. It sharpened. By adolescence, he had developed specific rituals around it, ways of positioning his leg when he sat so that the lower portion was out of his line of sight, ways of wearing his jeans so the shape of his calf was less visible. He began, in a way that would only make sense to him much later, to spend time online looking at photographs of people who had lost limbs below the knee, not in a voyeuristic way, in a way that felt like recognition, like seeing something he understood. He found the forums when he was 26. He had typed his symptoms into a search engine at midnight, the way people do when they have run out of other options. And within a few searches, he was reading accounts that mirrored his experience with an accuracy that left him sitting motionless at his desk for a long time. The relief was enormous. It was also immediately complicated, because what he was reading, these accounts of men and women who felt exactly as he did, was not reassuring in a conventional sense. Many of them had attempted to damage their limbs. Some had succeeded in obtaining surgical amputation through various means. Some had not been able to do either, and described decades of quiet suffering. The relief of knowing he was not alone was inseparable from the recognition that there was no clear path forward. He closed the browser. He went to work the next morning. He told no one. But something had shifted. He now knew what this was, or at least that it was something, and knowing it was something made it harder to keep it contained. For 3 years after finding the forums, Marcus maintained what he thought of as a controlled relationship with the condition. He read, he occasionally posted. He developed an understanding of his own psychology that was, in some respects, more sophisticated than what most clinicians at the time could have offered him. But understanding did not equal relief. If anything, the more clearly he could articulate what he felt, the more real it became. The ice bath night, the one he would later describe to a psychiatrist, was not the first time he had considered self-harm as a solution. It was the first time he had come close to acting. He had filled the bathtub. He had set a timer. He had read, in clinical detail, the expected progression of frostbite injury. He had prepared for it. What stopped him, he said, was not fear of death or pain. It was the thought of Diane finding him, the practical aftermath. He stepped back, he said, not because he wanted to, but because he was capable of strategic thinking, even in his worst moments, and the logistics were wrong. He told Diane 2 weeks later. He rehearsed it for days. He sat across from her at the kitchen table and described, in the most precise language he could find, what he had been experiencing since childhood. He watched her face move through several expressions she was clearly trying to control. She was a physical therapist. Her professional relationship with limbs was functional and restorative. What he was describing was its mirror image. She did not leave. She made an appointment with a psychiatrist who had experience with body image disorders. That appointment was, Marcus would later say, the most frightening thing he had ever done. more frightening than the bathtub, because the bathtub had felt like a solution, and the psychiatrist felt like an exposure. His diagnosis, when it came, was Body Integrity Identity Disorder. His psychiatrist told him, with a directness that Marcus respected, that there was no established treatment protocol, that the research base was thin, and that the two of them were, in some meaningful sense, navigating partly in the dark. What Marcus experienced at the bathtub, that convergence of precise, actionable planning and subjective certainty, is consistent with what neuroimaging research has begun to reveal about BIID at the biological level. Studies using functional MRI have found that when individuals with BIID touch or observe the limb they identify as foreign, there is measurably reduced activation in the right superior parietal lobule, a region of the brain critically involved in constructing the body schema. The body schema is the brain's internal map of the body, its size, its boundaries, its sense of ownership. It is not a conscious thought. It is a pre-reflective representation that operates below the level of deliberate awareness. In neurotypical individuals, touching a limb activates this region robustly. In BID sufferers, the activation is attenuated, as though the brain's map simply does not include that portion of the body. The limb is present in the physical world. It is absent from the brain's internal model of the self. This finding has led some researchers to characterize BID not as a psychological delusion or a psychiatric mood disorder, but as a neurological condition, a mismatch between the objective body and the brain's representation of that body. In that framework, the desire for amputation is not irrational. It is, from the inside, a logical attempt to reconcile an intolerable discrepancy. That interpretation has significant clinical implications. If the core problem is neurological rather than cognitive or emotional, then psychotherapy and medication, the conventional tools of psychiatric treatment, may address the distress surrounding the condition without touching its source. Indeed, most reported cases, including those in the literature Marcus had read, described treatments that reduced anxiety or depression without altering the fundamental sense of wrongness. The most controversial implication of this research is the one that the medical community has been slowest to engage with directly. If amputation of the identified limb resolves the distress, and there are documented cases in which it appears to, does that constitute a treatment? Or does facilitating amputation of a healthy limb represent a failure of medical ethics? That question does not have a settled answer. Marcus's psychiatrist held it openly, which was, Marcus said, the first time a clinician had treated him as someone capable of sitting with complexity. Marcus spent 2 years in twice-weekly therapy. His psychiatrist used a combination of approaches: cognitive work to address the anxiety and hypervigilance that had accumulated around the condition, and something closer to acceptance-based work that did not attempt to eliminate the underlying sense of wrongness, but aimed to reduce its capacity to dictate his behavior. It was not a cure. Marcus was clear about that. The feeling did not go away. The left leg still felt wrong. The boundary line was still there, exactly where it had always been. What changed, incrementally, was the volume, the degree to which the feeling consumed his attention on a given day. There were weeks that were manageable. There were nights that were not. He and Diane remained together. Their relationship was altered by the disclosure, not destroyed, but reconfigured. She understood the condition better than most people in his life would ever need to. She also understood, with the clinical clarity of her training, that there were limits to what proximity and love could remedy. Marcus did not pursue amputation. That was his choice, made with information, in consultation with his psychiatrist, and revisited periodically as research on the condition slowly accumulated. He did not rule it out. He did not make peace with the leg. He made a kind of armed truce with it, an ongoing negotiation between what his body was and what his mind insisted it should be. He still runs, 3 mornings a week, the same route. He has told one friend carefully, and the friend did not fully understand but did not leave either. He continues to work. He continues to draw buildings, structures designed to hold together, to bear weight, to stand. Body Integrity Identity Disorder forces a question that most of us never have to ask. What is the boundary between the self and the body? We assume, without thinking about it, that they are the same thing, that the skin is the self, that the limb is ours because it is attached. Marcus's case, and the cases of the thousands of people who share his experience, suggests that this assumption is a product of neurology rather than truth. The body schema can be incomplete, the brain's map can exclude, and when it does, the person living inside that mismatch must find a way to inhabit a body that does not feel entirely inhabited. What unsettles most about BIID is not the desire for amputation, it is the precision of it, the certainty, the fact that it begins in childhood and does not waver. That is not the signature of a delusion. That is the signature of something much harder to name. If you like Unsettling Psychology, like and subscribe for a new diagnosis each week.